Alright, welcome to our complete gynecology review for the USMLE. In this video over here, we're going to cover vulvar pathology, vaginal, cervical, uterine, ovarian, pregnancy, and breast pathology. And you can email me with any questions or comments that you have. Here we go. Let's begin with a quick review of female reproductive anatomy. And for that, I'm going to take you to an animation that I have. We see over here the uterus inside the pelvis. And we note that right in front of it is the bladder. Also over here, we note that right near the cervix is the ureter. This is so important because, as we'll see, a cervical carcinoma can cause renal damage by pressing on this ureter over here. That leads to hydronephrosis and damage to the kidneys. Then we take a little bit of a bigger picture over here, where we see the interior of the uterus. Well, first we see the vaginal canal. Then, of course, we get to the cervix. We see over here the small sperm entering the cervix. And the cervix has an ectocervix, also known as an exocervix, and an endocervix. We move up and we get to the uterus over here. Over here we see labeled the myometrium, that's made of smooth muscle cells, and in the inside we see endometrium. We're going to talk so much about the endometrium. Over here we see the fallopian tube, and we see the sperm traveling to the ovary. The ovum is released from the ovary, at which point it's known as an egg. This is where fertilization happens. If implantation happens over here, that's known as an ectopic pregnancy. We'll talk about that as well. And of course we're going to talk about pathology of the ovary itself. Lots of tumors associated with the ovary. And over here we see a poster showing the various ligaments of the uterus. Lots of ligaments, but I'm going to make this really easy and talk about the three most important ones, because they're the ones that house various vessels. The suspensory ligament of the uterus is also known as the infundibulopelvic ligament, and it's the ligament which connects the ovary to the lateral pelvic wall. The suspensory ligament, as you can see, contains various vessels. These are the ovarian vessels, that is, vessels which supply the ovary. The broad ligament connects the uterus to the lateral pelvic wall, and it also contains vessels. It actually contains the ovary and the fallopian tube, as well as the round ligament. And it's not a classic ligament. It's not like this long string. It's actually a fold of peritoneum comprising the mesometrium, mesovarium, and mesosalpinx. And then we get to the cardinal ligament. The cardinal ligament also has vessels inside of it, the uterine vessels. And the cardinal ligament connects the cervix to the lateral pelvic wall. So all these three ligaments which we discussed not only contain vessels, but they connect the female reproductive tract to the lateral pelvic wall. This is a distinction, for example, to the uterosacral ligament, which connects the cervix to the sacrum. Alright, with this discussion in mind, let's begin our discussion of pathology. Let's begin with our first question. A Bartholin cyst is caused by Bartholin gland obstruction? Absolutely, that's what causes it, or usually presents in the elderly. Well, it can present in the elderly, but it doesn't usually. It actually usually presents in women of reproductive age. So it's caused by Bartholin gland obstruction. We see over here the Bartholin cyst over here, usually unilateral. It could become infected and lead to abscess. And that's a rule in pathology. Anytime you have a blockage, it could lead to inflammation, and in this case, an abscess. Over here, I have this little mnemonic over here. I have the big violin for Bartholin, and it's blocking the duct, which reminds us that there's a blocked duct. And over here, the duct is on fire, reminding us that it could lead to inflammation. Lichen sclerosis presents with intense pruritus, dyspareunia, and dyschezia, or is malignant. So it's not malignant, it's benign, and it does present with itchiness and these other symptoms. And it's a very common condition. And as we can see in the picture over here, it's characterized by these porcelain white plaques. And these plaques can be ulcerated or hemorrhagic. Generally, they occur in peri-postmenopausal females. And what's most high yield about it is that it can lead to squamous cell carcinoma. There's an increased risk for squamous cell carcinoma. And I have that little mnemonic over here, lichen sclerosis. Ich for itchy, and SC for squamous cell carcinoma. Just keep that in mind. Question number 3, lichen simplex chronicus presents with leathery vulvar skin. That's what it's all about, and it's not malignant, it's benign. So it presents with leathery vulvar skin. We see that over here. This is not what it looks like. I just have this picture of leather over here to remind us of the lichen simplex chronicus, that it presents with leathery vulvar skin. And what it's actually due to is chronic rubbing or scratching. This chronic rubbing and scratching leads to hyperplasia of the vulvar squamous epithelium. Over here, I have this little mnemonic over here. This lady who is a tanner, she's saying, leather? I like it simple. She likes simple leather. Simple for simplex chronicus, lichen simplex chronicus, and leather for the leathery vulvar skin that we see. And perhaps this lady over here was scratching or rubbing the leather, which reminds us that it's caused by rubbing and scratching, which leads to hyperplasia. One more thing about lichen simplex chronicus is that it does not pose an increased risk for squamous cell carcinoma, as opposed to lichen sclerosis. Question number 4, vulvar cancer can result from long-standing lichen sclerosis? Absolutely, that's what we just said, that it could lead to squamous cell carcinoma of the vulva. Is it associated with HPV? Yes. So we're going to go with C. Both A and B are true. And these are actually the two different forms of vulvar cancer. Vulvar cancer actually has two forms. The non-HPV related form, and this usually results from long-standing lichen sclerosis, which is what we spoke about. And this presents in older females, like older than 70, as opposed to the HPV-related one seen in younger patients, perhaps patients in their 40s or 50s, especially patients who had multiple partners. And the cancer presents as leukoplakia. We see a picture of that over here, where we see the vulvar cancer. Now, of course, we need to biopsy it, so we know exactly what we're talking about, but this is what vulvar cancer looks like. Extramammary Paget disease is associated with an underlying carcinoma? That's tricky, but I'm going to go with no. Pruritus, erythema, and crusting, yes. Why did I say it's tricky? Because Paget disease of the breast is associated with an underlying carcinoma. That's in distinction to Paget disease of the vulva, which is not associated with an underlying carcinoma generally. We see Paget disease leading to ulcerations. That's what it involves. It involves pruritus, erythema, and crusting. Now, Paget disease always involves malignant cells. It's not benign, it's malignant cells. They're malignant epithelial cells in the epidermis. It could be in the nipple or it could be in the vulva. And in this case of extramammary Paget disease, we're talking about the vulva. Over here we see the histology where we see these malignant epithelial cells. It's going to look just like this in the breast as well. We see these malignant epithelial cells over here in the epidermis. Now, how would you know that we're not talking about a melanoma? Sometimes it's not so easy to tell Paget disease of the vulva from melanoma. How would we distinguish the two? So what we would do is we would check for certain markers. For as you know, Paget disease is a carcinoma, and therefore it's going to have keratin. It's going to be keratin positive. Keratin is an intermediate filament in epithelial cells, which is associated with carcinomas, as opposed to melanoma, which would not have the keratin. So if we see that it's keratin positive, it's probably Paget disease and not a melanoma. Another thing that we could do is look for S100. As we'll see in our dermatology lectures, melanoma is S100 positive. So if it's S100 positive, it's probably melanoma and not Paget disease. And over here I have a mnemonic for that. We have the carets, reminds us of keratin, and the CAR for carcinoma. That keratin is associated with the CAR, the carcinoma. And this is associated with Paget disease, extramammary Paget disease, which is a carcinoma, and of course not melanoma. All right, imperforate hymen, if untreated, leads to amenorrhea. Of course, her hymen is closed up. She's not going to have her period. And abdominal pain, yes, because of the buildup. Does it lead to menorrhagia? No, she's not going to be bleeding. Over here we see a picture of the imperforate hymen, and this is due to incomplete degeneration of the central portion of the hymen. And of course, the amenorrhea is simply because the vaginal canal is physically blocked. And how do we treat it? The surgeon makes a small cut or incision and removes the extra hymen membrane. Vaginal squamous cell carcinoma is usually primary? No, it's usually secondary to cervical squamous cell carcinoma, and it is actually the most common cause of vaginal cancer. Now just remember that vaginal cancer is pretty rare. Vaginal squamous cell carcinoma is still pretty rare, but of the vaginal cancers, the most common cause is squamous cell carcinoma, secondary to cervical cancer. All right, question number 8. Clear cell adenocarcinoma of the vagina arises due to persistence of squamous epithelium? No, it could arise due to persistence of columnar epithelium, which we'll talk about. Is it associated with DES exposure? Absolutely. As they realized over the years that mothers who took DES while pregnant, their daughters were the DES daughters. Their daughters were developed certain conditions, one of them being clear cell adenocarcinoma of the vagina. And the reason why this happened was because the DES exposure led to retention of columnar epithelium in the vagina. Now, persistence of columnar epithelium in the vaginal canal increases risk of clear cell adenocarcinoma. You see a picture of the clear cell adenocarcinoma over here, and we see the glandular columnar epithelium associated with the adenosis, which leads to the clear cell adenocarcinoma in this picture over here. And here I have this little mnemonic. We have the baby inside the tummy, and she's saying to her mother, "Don't take DES, are we clear?" So she's saying, don't take DES, are we clear? To remind us of clear cell adenocarcinoma is associated with DES, and the columns, really random to have columns inside the mommy's tummy, the columns reminds us of the columnar epithelium leading to the adenosis and associated with clear cell adenocarcinoma. Sarcoma botryoides affects older females or shows spindle-shaped cells and is Desmond positive, so it does not affect older females. It's actually a condition that affects younger kids, like less than 4. And it shows, and on histology, it shows spindle-shaped cells and is Desmond positive. Over here we see the grape-like mass coming out of the perhaps 3-year-old baby's vaginal canal, and if you look at the histology, it shows spindle-shaped cells and is Desmond positive. Why is Desmond positive? Well, let's remind ourselves. Here we see this little animation over here that I made. Someone botched, they did something interesting with this vaginal canal, botched for botryoides, and there are grapes inside the vaginal canal. And this muscle over here, coming out of the side of the vagina over here, reminds us what botryoides is all about. It's a malignant proliferation of immature skeletal muscle. That's why it's Desmond positive. It's also myogenin positive. These are markers for skeletal muscle, immature skeletal muscle. Cervical dysplasia begins at the basal layer and extends outward. Absolutely. Typically presents with pain. No, it does not. That's why you need to check all the time to make sure that the woman doesn't have it, because she's not going to feel it. It may present as abnormal vaginal bleeding, especially postcoital, but it is going to be generally asymptomatic. And over here we see the development of the dysplasia going from CIN1 to CIN2, perhaps to CIN3, and then eventually potentially, if it were to go through the entire thickness of the cervical wall, that would be an invasive carcinoma in situ. Once it becomes an invasive carcinoma in situ, it's completely and entirely irreversible. CIN3 is almost entirely reversible, but it could be reversed in rare cases. When it's in situ, it's completely irreversible. And which virus is it associated with? HPV-16 and HPV-18. Let's talk about this. HPV produces two gene products, E6 and E7. E6 inhibits P53 and E7 inhibits PRB. These are both tumor suppressors. P53 regulates the G1 to S phase, and if there's too much damage, it calls in BAX to knock out BCL2 to activate apoptosis. So if we lead to destruction of P53, it's going to lead to mutations because there's going to be less apoptosis when we want it. And RB required also for progression in the cell cycle. So if we knock out P53 and we knock out PRB, it's going to lead to proliferation when we don't want it. That's how HPV works. It leads to progression of the cell cycle when we don't want it, i.e. when there are mutations, and that's how HPV leads to mutations, i.e. cancer. Here we see the Elon sticks to remind us of E6, and he's destroying the 53rd bank over here to remind us that E6 is the one associated with P53, and therefore E7 is associated with RB. There's going to be unchecked cell growth, and that's what leads to the tumors. Question 11. What histologic finding is associated with cervical dysplasia, coilocytes, or giant cells? It is the coilocytes. That's what you look for. I like calling them coiled up raisins. Well, they look like coiled up raisins under the microscope. Coiled up reminds us of coilocytes. And where do we see these coilocytes? Not only in high-risk HPV. High-risk HPV are the 16 and 18 ones, as well as 31, 33, and others. We don't only see coilocytes in the high-risk ones, we also see them in the low-risk ones. And I have this picture over here of HPV leading to the condyloma, the low-risk one, those are caused by HPV 6 and 11, and the cervical dysplasia caused by 16 and 18. He's sad because those are the high-risk ones. And again, in all of these cases, we're going to see the coilocytes. Question 12. How does cervical carcinoma lead to renal failure, tumor cell cytokine release, or physical blockage of the ureters? It's going to be physical blockage of the ureters. That's what happens. The tumor, when it grows in the cervix, it grows laterally, and therefore it blocks the ureters. Small picture of that over here. And since it blocks the ureters, the urine goes back up, leading to hydronephrosis, leading to renal failure. That's actually one of the most common causes of death in patients with cervical carcinoma. And now it's important to get a pap smear before it progresses to invasive carcinoma, and therefore it's so important to get a pap smear for other reasons as well before it progresses to invasive carcinoma while it's still a dysplasia. I have this little animation over here. And we see the cervix is over here, and lateral extension, of course, would lead to blockage of the ureters. And here we see the histology just to remind us of the difference between the exocervix and the endocervix. The ectocervix, or the exocervix, has squamous epithelium, we see that over here, and the endocervix has columnar epithelium. Between them, it is the transformation zone, and that's where it's so important to perform the pap smear at the transformation zone, because that's where HPV tends to infect. Question 13. Primary ovarian insufficiency makes pregnancy impossible? No, it's not impossible. It is diagnosed when FSH is high and estrogen is low. Yes. We look for these values, FSH and estrogen. By the way, primary ovarian insufficiency is also known as premature ovarian failure, and it is specifically in women under the age of 40 who present with symptoms of menopause. They shouldn't be having menopause. They're young. They're 25. They're 30. They may be 18 years old. All right, here we have primary ovarian insufficiency is diagnosed with FSH is high and estrogen is low. Now, what does primary ovarian insufficiency put a woman at risk for? Well, for one thing, osteoporosis. Why? Because she has low estrogen. So actually, women with primary ovarian insufficiency in 15% of cases present with osteoporosis. Over here, we just have the fish flying over the lady with the primary ovarian insufficiency. Fish for FSH. FSH is high in primary ovarian insufficiency. Which of the following can cause anovulation? All of these things can cause anovulation. Eating disorders, obesity. Well, let's just talk about why. Eating disorders, the ovaries shrink. Obesity, increased estrogen. Leads to negative feedback. Polycystic ovarian syndrome, which we'll talk about more, leads to androgen overproduction. Thyroid disorders, hormone imbalances. Primary ovarian insufficiency leads to ovarian failure, as we spoke about. And athletics, which we'll speak about more also, leads to exercise hormonal imbalance and low body fat. And we'll talk more about that. And Cushing syndrome leads to elevated androgens from the adrenal glands. In patients with exercise-induced amenorrhea, LH levels will be reduced. LH levels will be reduced. Over here, we have this lady over here. She has exercise-induced amenorrhea. She's very skinny. We actually don't even see her torso that she's so skinny. And she's stepping on the luge guy for LH. She's also stepping on the estrogen over here. Estrogen levels will be low also, and the fish for low FSH levels. By the way, exercise-induced amenorrhea is also known as functional hypothalamic amenorrhea because it's affecting the brain. It's affecting the hypothalamus due to the severe caloric restriction. She's exercising. She's not gaining weight. She's eating low-fat foods, perhaps. This leads It's a disruption of GnRH secretion leading to reduced LH-FSH and estrogen. And she's going to stop menstruating and she will have decreased bone density due to the decreased estrogen. All right, which of the following are seen in polycystic ovarian syndrome? All of the above. We see elevated androgens. Exact cause is debated, but we see elevated androgens and we see hirsutism and acne often. We don't have to see it. We often see hirsutism and acne. Decreased rate of follicular maturation, of course, that's what defines the disease. Cystic ovaries on ultrasound, that also defines pathological finding. Obesity, often, classically, we don't have to see obesity, we often find it. Increased risk of endometrial cancer because of the unopposed estrogen from lots of anovulatory cycles. And just associations that we want to be aware of as well are insulin resistance, that many of the patients have insulin resistance, so they may develop type 2 diabetes. And over here we see lots of signs for androgen, and we see the obese woman with hirsutism over here looking at her polycystic ovary. Again, we don't need to see the hirsutism and obesity. It is classically seen with polycystic ovarian syndrome. Here we see the ultrasound over here. Management for polycystic ovarian syndrome is quite complicated for our purposes. It may involve progesterone. It may involve birth control. But we want to remember that spironolactone and finasteride may be given to treat the hirsutism and clomiphene to induce ovulation. We want to induce ovulation, as well as drugs to prevent endometrial hyperplasia due to the unopposed estrogen. Question 17, what is the first-line treatment for primary dysmenorrhea, NSAIDs, and hormonal contraceptives? She won't be able to get pregnant until she gets off the hormonal contraceptives, but if we want to help her with her pain, we will give her hormonal contraceptives. The woman just received her HPV vaccine. Does she still need a pap smear? Absolutely. HPV vaccine only protects against subtypes 6, 11, 16, and 18. It doesn't protect against 31, 33, etc., other variants, and therefore she still needs the pap smear. How often? About every 5 years, 3 to 5 years. Some OBGYNs even give it every year because they want to prevent the dysplasia, if it's there, to progress to invasive carcinoma. Over here we see what the pap smear looks like. Over here we see the precancerous or cancerous cells with the large nuclei in the middle. That's what they look like. This is in contrast to the koilocytes. Remember, don't confuse this with koilocytes. Koilocytes refer to HPV-infected cells. Those are the shrunken up, raisin-looking cells, the raisin nuclei cells. These are precancerous cells over here, and that's what we want to look for in the pap smear, along with koilocytes. Adenosis of the vaginal canal is the pathologic persistence of, and let's just take a moment over here to talk about the embryology of it. The vaginal canal is actually composed of 2 different embryonic structures. The bottom third is derived from the urogenital sinus, and the top 2/3 from the Mullerian duct. The bottom 1/3 is composed of stratified squamous epithelium, and the top 2/3 of columnar. During development, the stratified squamous replaces the whole vaginal canal, so the entire vagina is of stratified squamous epithelium. Adenosis is the persistence of the upper 2/3 with columnar epithelium, and as we spoke about before, this is associated with DES exposure. Question 20, adenomyosis involves, this is dysmenorrhea and abnormal uterine bleeding. That's what we find. We find dysmenorrhea and abnormal uterine bleeding. We don't see a small uterus, we see a large uterus. It's getting bigger from the endometrial tissue, which extends into the myometrium, leading to bleeding. A lot of sources consider adenomyosis a form of endometriosis. Endometriosis is when any endometrium tissue ends up outside of the endometrial cavity. Over here, it ends up in the myometrium. Asherman syndrome is associated with DNC, unfortunately, associated with DNC, that if a woman gets an overaggressive DNC, it can lead to Asherman syndrome, in which she gets fibrosis and tissue scar formation in the endometrium, leading to reduced fertility or infertility. And the reason is because she loses the functional layer of the endometrium, the basalis, the regenerative layer, and this is what leads to the infertility. And over here we see the gynecologist, the Israeli gynecologist, who is the one who described the condition, and it's sometimes helpful to remember diseases when we see a picture of the people who are involved. Here we just see a histology of the endometrium. Endometrium, just to remind us, is the inner lining of the uterine cavity, and it's made up of stroma and glands, and the myometrium is made up of smooth muscle cells, as we can see over here, the smooth muscle cells. Endometrium, we just remember, is estrogen driven, and that's why it changes with proliferative phases and progesterone phases of the menstrual cycle. It sheds with the loss of progesterone support during the second phase, and that results in menstruation. Question 22, endometrial hyperplasia presents as postmenopausal vaginal bleeding, or it does not increase the risk of endometrial cancer. It definitely does increase the risk for cancer, but it presents as postmenopausal vaginal bleeding. And the defining feature of this is overgrowth of glands relative to stroma. That's what we see. And again, this is due to unopposed estrogen. That's why we see this in postmenopausal women, because they have unopposed estrogen. This is especially true if she's obese, so she's producing extra estrogen. Now, if we take a look at this histology, how do we know if it's likely to lead to a carcinoma? If we see nuclear atypia. How do we stop the endometrial hyperplasia? We give her progesterone to make sure that the estrogen is no longer unopposed. Question 23. Endometriosis refers to glandostroma outside the endometrial cavity. That's what it's all about. Or refers to inflammation of the endometrium. No, that's endometritis. Endometriosis is glandostroma outside the endometrial cavity. It's most common in the ovary, the pelvis, and the peritoneum. In the ovary, it appears as what is called a chocolate cyst. We see it over here, the chocolate cyst over here on the left. And on the right, we see when it ends up in the peritoneum. Then it shows up as yellow powder burn lesions. And over here we see the different places where the endometriosis could form. It could form in the fallopian tube and in other places. How does it form? How does a chocolate cyst form? Well, there's endometrial tissue there. So it grows and it sheds, and it grows and it sheds with the woman's cycles. And it's kind of like the uterus itself. It grows and sheds, and eventually it leads to the formation of the chocolate cyst. Question 1084. Endometriosis presents with, how's the woman going to present? With pelvic pain and abnormal uterine bleeding. And it could lead to infertility. So before, endometriosis refers to glandostroma outside the endometrial cavity. By the way, how does endometriosis form? Actually, different theories about it. One of them, which is the leading theory, is a retrograde menstruation theory, that menstrual products go back up outside the endometrial cavity. But some argue that it can't just travel retrograde, because then how do you get it in the lungs? We've seen endometriosis in the lungs before. They say it has to come from the lymphatics. Just be aware. All right, question 24. Endometritis is due to, this is retained contraception products following delivery or an abortion. It leads to inflammation of the endometrium, and a patient after, let's say, a few days after birth could present with fever and pelvic pain because of the infection. And we treat it with various antibiotics such as gentamicin and clindamycin, possibly ampicillin. And here we just see inflammation of the endometrium. Question 25. The most common gynecologic malignancy is endometrial carcinoma. Leiomyoma is not a malignancy, that's just a tumor. And there are different pathways for the endometrial carcinoma, the hyperplasia pathway and the sporadic pathway. Hyperplasia pathway leads to endometrioid form, and the sporadic form leads to the serous form with papillae and tufts. Just an example of endometrial cancer, which is true regarding the endometrioid carcinoma. Its most causes are caused by obesity-related unopposed estrogen. Again, this is the hyperplasia pathway associated with obesity. And histology is going to show abnormally arranged endometrial glands. Question 27. Histology of Leiomyoma shows whorly patterns. That's what we see in Leiomyoma. We see whorly patterns of smooth muscle bundles. I imagine a person lying down on these smooth muscle fibers, lying down for Leiomyoma, and reminds us of the whorled pattern of smooth muscle cells. We remember that Leiomyoma often presents as multiple discrete tumors, and there's an increased incidence in Black patients. Now, transformation to leiomyosarcoma is rare, very, very rare, but it is possible in very rare cases. Now, the tumor increases in size with pregnancy and decreases with menopause due to changing estrogen levels. So this is really interesting. It's estrogen sensitive. The Leiomyoma is estrogen sensitive, and therefore will change accordingly. And there's a peak incidence of patients from the ages of 20 to 40. Are these symptomatic? No, they're usually asymptomatic, but could lead to abnormal uterine bleeding or even miscarriage because the leiomyoma physically blocks the egg from implanting in the uterus. Question 28. Leiomyosarcoma presents in postmenopausal females or arises from leiomyoma. As we mentioned, it generally does not rise from leiomyoma. It presents in postmenopausal females. And this is opposed to a leiomyoma. Generally doesn't occur after menopause because it's estrogen driven. It's generally before menopause, where there's more estrogen. Leiomyosarcoma presents generally in postmenopausal females. Follicular ovarian cysts, are they common? Extremely common, and they usually resolve spontaneously. For here we see the different forms of cysts. We see the follicular cyst. The follicular cyst is the most common type, and it's caused by failure of the mature follicle to rupture and ovulate. And this usually, as we mentioned, resolves spontaneously. And we see the corpus luteal cyst. This is another functional cyst, and is caused by failure of the corpus luteum to involute, and may produce excess progesterone. And it usually, again, resolves spontaneously. And there's also a theca-lutein type, which we don't see here, and that's caused by HCG overstimulation. Right, question 30. Which of the following are risk factors for ovarian tumor? So it's going to be older age, early menarche, late menopause, endometriosis, and BRCA1 mutation. A general rule to keep in mind: more ovulations, more ovarian cancer. Somehow the ovulations lead to ovarian cancer, somehow. So let's see, who's going to have more ovulations? A woman who's older, she's already had more ovulations in her life. Early menarche, she started having ovulations when she was younger. Late menopause, she continued having ovulations into her later years. So again, more ovulations, more ovarian cancer. That's why a lady who's pregnant, or a lady who nurses, or a lady who takes contraceptives, all these things over here in choice B, they lead to reduced ovarian cancer because she has less ovulations. Question 31. Ovarian germ cell tumors arise from the egg, right? We see the egg is what leads to the germ cell tumors, the ovary surface epithelium leads to epithelial tumors, and the stromal follicle leads to sex cord stromal tumors. Let's just remind ourselves that the epithelial tumors are the most common type, and these are typically serous or mucinous. And what we do is we look at grossly, and if it's watery, it's usually serous, and if it's mucousy, we call it mucinous. Of course, we can also see these features under the microscope. In terms of germ cell tumors, they can differentiate into somatic structures, such as teratomas, or extraembryonic structures, such as yolk sac tumors, or remain undifferentiated in a dysgerminoma. Sex cord stromal tumors develop from embryonic sex cord, develop into theca and granulosa cells of the follicle. By the way, there's actually a fourth type of ovarian tumor which we're going to talk about, and this is due to metastasis. But here we're referring specifically to primary ovarian tumors. We'll get to the secondary ones. Question 32. Cystadenomas are benign. They're benign. And there's a serous form and a mucinous form. Serous form is the most common form, and it's lined by fallopian tube-like epithelium. The mucinous type is large, lined by mucus-secreting epithelium. Question 33. Serous adenocarcinoma. So now we're talking about a carcinoma where it's malignant. It involves pseudomyxoma bodies, not pseudomyxoperitoneae. The mucinous ones result in pseudomyxoperitoneae. Now, the serous adenomas tend to present late. That's why they have a poor prognosis. They present with abdominal pain and problems with urination. Brenner tumors are urothelial-like. Just remember, Brenner are bladder-like. Brenner for bladder. CA125 is a useful marker for we don't generally use it for screening. It's generally for relapse or response to therapy. That's why we use it as a screening test for that. Question 35. Germ cell tumors generally appear in younger or older women. Younger women, that's what germ cell tumors are all about. They present in younger patients. The benign surface epithelium in about the middle-aged patients, and the malignant surface epithelial ones present in older ladies. Mature cystic teratoma is all of the above, a type of germ cell tumor, and it's benign. So it's benign, but we want to check to make sure it doesn't grow, because if it grows, it could lead to problems. For example, one that it could lead to is an adnexal torsion. We know that if things get too big in the ovary, it could lead to an adnexal or an ovarian torsion. So let's talk about the other things over here. It's most common ovarian tumor in young females. Yes, it's formed of elements from all three germ layers. That's what teratoma is all about. They're formed from all three germ layers. That's why we find teeth, hair, and other things there. And it may present with hyperthyroidism in struma ovarii, where we see thyroid tissue inside the ovary, and it can lead to hyperthyroidism. Over here we see a picture of a teratoma. Pretty nasty. I hope you're not eating anything. Question 37. Immature teratoma is malignant and aggressive? Absolutely. And it's usually diagnosed before the age of 20. This germinoma shows uniformly fried cells, yes, decreased HCG and LDH, now has increased levels of HCG and LDH, and we see the fried egg appearance. So dysgerminoma, fried eggs. Perhaps you can imagine a person saying, "The germs are on your fried eggs." Germs on fried eggs for fried egg appearance in dysgerminoma. Question 39, yolk sac tumors. Let's see, all of the above. I'm just going to give it away. It's also called an endodermal sinus tumor, and it's the most common germ cell tumor in children. 50% of the time we find also Chival-Duval bodies. So the yolk sac, remember, Chival-Duval. Over here we see the Chival-Duval body. It kind of looks like a glomerulus, but it's not. It looks like a glomerulus. This represents blood vessel in the center with the layers surrounding it, seen in yolk sac tumor. So yolk sac tumor, we see the glomerulus of the Chival-Duval body. Carcinoma is a malignancy of placenta-like tissue. Yes, it's the trophoblast, and it does spread hematogenously. It spreads very quickly hematogenously, even to the lungs, where it can cause cannonball lesions, as we see over here. And patients present with abnormal uterine bleeding, dyspnea, and hemoptysis. Now, we could treat it. We would give methotrexate and chemo, but it is treatable, but it does spread hematogenously. And it often commonly occurs after an abnormal pregnancy, such as a complete hydatidiform mole or an abortion, and it can even occur non-gestationally in the gonads. Sex cord stromal tumors include all but yolk sac tumor. The other ones are sex cord stromal tumors. Yolk sac tumor is a germ cell tumor. Again, sex cord stromal tumors are tumors that arise from the stroma, so they resemble the normal sex cord stroma tissue of the ovary. We're going to see granulosa and theca cells. We're going to have fibrous tissue, Sertoli and Leydig cells. All of these can develop into tumors, leading to fibroma, thecoma, Sertoli Leydig cell tumor, and granulosa cell tumor. Question 42, granulosa cell tumor is all of the above. It's the most common malignancy sex cord stromal tumor. It produces estrogen and can also produce progesterone. Now, symptoms vary with age, but it often occurs in post-menopausal women, and it causes bleeding because of the excess estrogen. The association that we want to be aware of is the Call-Exner bodies. Over here we have the Call-Exner bodies, the histology of them. We have a guy calling Granny over here to remind us of the Call-Exner bodies associated with the granulosa cell tumor. Again, Granny for granulosa, and we see the Call-Exner bodies. These are granulosa cells among eosinophilic fluid. Question 43, Sertoli Leydig cell tumors of the ovary are malignant, resemble testicular histology? Yes. And if we were to take a look at it, we would see a gray to yellow-brown mass. And these cells would actually produce androgens, and it could even lead to virilization, such as hirsutism and male pattern baldness. Fibromas are malignant? No, but they can cause Meig syndrome. That's a triad of ovarian fibroma, ascites, and pleural effusion. Krukenberg tumor, this is the metastasis one. Krukenberg is all about metastasis. A malignancy in the ovary that metastasizes from a primary site, primarily the GI or the breast. All right, question 45. Ectopic pregnancy occurs most often in the ampulla. It could occur in the isthmus. It could occur in other places as well. It could even occur in the liver, but it most commonly occurs in the ampulla. Over here we have a video that I made of a woman over here who's pregnant, and she dropped some eggs from her ice cream. These are the egg toppings for ectopic onto her uterus ampulla. Other associations about ectopic pregnancy. Risk factors include tubal pathologies, especially with scarring from, let's say, a PID. It could also be associated with a previous ectopic pregnancy, IUD, and IVF, and it presents with first trimester bleeding and or abdominal pain. What we're going to see is that there's going to be a lower than expected rise in HCG, and we treat it with methotrexate and or surgery. Which is true of placenta previa. So it is attachment of the placenta over the internal cervical os. Over here we see placenta previa. We see a preview of the placenta through the vaginal canal. And the problem over here is that if the cervix starts to dilate, it could cause tremendous hemorrhage because the placenta is going to be separated from the lining of the uterus. Question 47, which is true of placental abruption? It presents with abrupt, painful vaginal bleeding. And this occurs generally in the third trimester. It can lead to maternal hypovolemic shock due to the blood loss, and the patient could go into DIC, and this is actually due to release of tissue factor from the injured placenta, and it's life-threatening for the mother, and it's life-threatening for the baby. Which is true of placental accreta. It is attachment of the placenta to the myometrium. Normally, the placenta should be attached to the decidua basalis. In placenta accreta, it's attached to the myometrium, and it can even get stuck there, and when the baby is born, the placenta just remains, and removal of it could lead to hemorrhage. So it's generally extracted in pieces. It could even in some cases lead to hysterectomy because of the concern of tremendous hemorrhage to the mother. Now, increta is when it actually goes further into the myometrium, and percreta is when it goes into nearby organs, such as the bladder. But accreta is just simply attachment of the placenta to the myometrium, which itself is actually could be very dangerous. 49, which is important in diagnosis of gestational hypertension, is basically a woman with high blood pressure who did not have a pre-existing hypertension. We treat it with antihypertensives such as hydralazine, alpha-methodopa, which is used less nowadays, labetalol, and nifedipine. And there's just an interesting mnemonic. Hypertensive moms love nifedipine, hydralazine, methyl-dopa, labetalol, and nifedipine. Again, methyl-dopa is not used as much these days. Question 50. What is preeclampsia caused by? Abnormal placental spiral arteries. How do we treat the mother? We give antihypertensives, but we may perhaps give IV magnesium sulfate to prevent seizures, because once there are seizures, that's eclampsia. And the definitive treatment of eclampsia is delivery, because once the placenta is out, the problems start to resolve because the problem was caused by the placenta. HELP is a related syndrome. That's where we see preeclampsia with thrombotic microangiopathy of the liver. So we see low platelets and elevated liver enzymes, along with hemolysis. On histology, we see schistocyte. We also see that in two conditions, hemolytic uremic syndrome and TTP. How is HELP treated? Again, with delivery. HCG levels in a patient with hydatidiform mole are elevated. They're going to be actually super elevated in the complete form and mildly elevated in the partial form. Let's take a moment to talk about the two forms of hydatidiform mole. There's the complete form and the partial form. In the complete form, there's no DNA inside the egg. The egg is empty and 2 sperm come inside of the egg. In the partial form, the egg is still there and 2 sperm come along. So in the partial form, there's going to be 3 times the normal amount of DNA. In a complete form, there's going to be twice the normal amount of DNA. In the complete form, it's entirely molar, and therefore HCG levels will be completely elevated. Over here, we see the complete form and the partial form. How is the patient going to present? Vaginal bleeding, uterine enlargement. She may be vomiting. How do we treat it? With DNC and or methotrexate. 46 chromosome hydatidiform mole is we said already, that's the complete form. Again, in the complete form, 2 sperm combined with an egg that has lost its DNA. It could also actually be a single sperm which duplicates its DNA. In the partial form, there are 2 sperm and 1 normal egg. Only in the partial form will there be fetal tissue, right? Over here we saw the partial form. Only in the partial form will there be fetal tissue, because we both have the sperm and the egg, as opposed to in the complete form, as opposed to in the complete mole, there are no fetal parts because we don't have any egg DNA. And which form is a risk factor of choriocarcinoma? That's the complete form, and that occurs in about 2 to 3% of cases, and that makes a lot of sense. Choriocarcinoma is a tumor composed of trophoblasts, and that's exactly what hydatidiform mole is. It's trophoblasts and syncytial trophoblasts, and that's why it could lead to choriocarcinoma. But this is only associated with the complete form, not generally with the partial form. All right, let's start talking about breasts. Myoepithelial cells and luminal cells are a component of both the lobules and the ducts. We recall the lobules and the ducts of the breast over here, and both of them are composed of 2 layers, the myoepithelial cells and the luminal cells. And we have a really good picture of that over here, where we see the 2 layers, the myoepithelial cells close to the basement membrane and the luminal epithelial cells in the center. Which pathogen causes acute mastitis? That's going to be Staph aureus. What is acute mastitis? It's a bacterial infection most commonly seen in the postpartum period. Bacteria, Staph aureus, invades the breast through the small erosions in the nipple. What's really interesting is that we don't only treat with antibiotics and drainage, but we also treat it with continued breastfeeding. The continued breastfeeding actually helps clear the infection. And we have a picture of the acute mastitis. We see the inflammation. Fat necrosis of the breast is not malignant. It reveals a calcified oil cyst on biopsy, which we see over here, the fat necrosis on biopsy. A woman may not realize that she has fat necrosis. She may have gotten hit, or she may have fallen on her breast and she got this fat necrosis and she didn't even realize that it caused this lesion over here. The reason why it's so important is because we want to look under biopsy and we see calcifications. Calcifications, as we will see soon, are associated with certain malignancies, but it's not always associated with certain malignancies. And for example, fat necrosis of the breast leads to these calcified oiled cysts and is of course not malignant. Fibrocystic changes occur most commonly in older women. No, it's usually not a risk factor. Cancer, don't worry about fibrocystic changes. They generally occur in premenopause females from the ages of 20 to 40 due to changing hormone levels present in the blood. Now, why is it called fibrocystic changes? Well, we have the lobule and it has glands. The glands become bigger. These are the cysts, and the cysts stretch out the connective tissue, leading to fibrosis. So that's the fibrosis aspect. Fibrosis and cysts, and presents with premenstrual breast pain. And if we take a look at the exam of the cysts, we see these blue dome look to them because of the stretching. Here we see the blue dome look of the cysts, of the fibrocystic changes. Epithelial hyperplasia is associated with a twofold increased risk for cancer. Yeah, we're talking about a slight increased risk for cancer. In this context, that would be something like sclerosing adenosis. Sclerosing adenosis is when there's fibrosis of the acini and the stroma associated with calcifications also. Just like fat necrosis was associated with calcifications, so is sclerosing adenosis. But there's only a slight increased risk for cancer, as opposed to epithelial hyperplasia of the cells in the terminal duct or in the lobular epithelium that doubles the risk for carcinoma. And if we see atypia, then there's going to be a 5 times increased risk for an invasive carcinoma. Intraductal papillomas are associated with bloody discharges. We always see bloody discharges with these papillomas. They tend to bleed and exit through the nipple. We distinguish a intraductal papilloma with, let's say, a papillary carcinoma. And first of all, in the carcinoma variant, there are no myoepithelial cells. In the intraductal papilloma, we will see myoepithelial cells. And in the carcinoma, it presents in older ladies generally. In the intraductal papilloma, we generally see not in older patients, we see in younger patients. Fibroadenoma is all of the above. I wrote fibroadenoma, made that in red. It's really all of the above. It's mobile, it's estrogen sensitive, it's benign. She shouldn't worry about it. It's more common in females under than 35, and it is estrogen sensitive, which increase in size when? During pregnancy or prior to menstruation. Question 62, phyllodes tumor contains a fibrous overgrowth leading to leaf-like projections? Absolutely, that's what phyllodes means. It means a leaf. We see these leaf-like projections. So again, this is the fibrous overgrowth, and it's most common in women in their 40s. DCIS, let's talk about these cancers over here. Involves basement membrane invasion? No, it has not invaded the basement membrane yet. That's when it's invasive. Here it's just in situ. It's a malignant proliferation. And I made a smiley face over here because this was an obvious question. Eventually, when it goes through the lymphatics, we call it metastatic. And by the way, what is DCIS called when it makes its way up to the nipple? That is Paget's disease of the nipple. That's exactly what Paget's disease of the nipple is when DCIS, ductal carcinoma in situ, makes its way up to the nipple. Question 64, DCIS, what does it do? It fills the ductal lumen, yes. It appears as calcifications on mammogram, yes. Are calcifications always indicative of malignancy? No. Fat necrosis, for example, adenosine sclerosis, for example. But if we do see calcifications, we have to be worried about DCIS, and it arises from ductal atypia. A subtype of DCIS in which cells have high-grade nuclei with extensive central necrosis is comitocarcinoma. It's just a form of DCIS, ductal carcinoma in situ, where we see the central necrosis with lots of atypia. And I have this comedian over here to remind us of comitocarcinoma. Paget's disease of the nipple is associated with underlying malignancy? Yes, remember we distinguished this from the vaginal canal, the vulva, where Paget's disease was not associated with an underlying carcinoma. Invasive ductal carcinoma of the breast, both A and B are true. Forms a firm, fibrous, rock-hard mass with sharp margins and may cause nipple retractions. Paw d'orange, I don't even know how to pronounce it, okay? Inflammatory carcinoma of the breast, appears warm, swollen, and red. And is it bad? Yes, it is extremely aggressive. We're going to see invasion of the lymphatics. That's why it's such poor prognosis, because it invades the lymphatics. By the time we discover it, it's already gone to other places in the body. And we don't necessarily find any palpable mass present. By the way, inflammatory carcinoma of the breast would sometimes be mistaken for mastitis or even Paget's disease. Medullary carcinoma can look like a fibroadenoma, absolutely. Appears as large anaplastic cells growing in sheets. Is the medullary carcinoma. We see these large anaplastic cells growing in sheets, and it's associated with BRCA1 mutations. LCIS, It's defined by the lax E-cadherin. That's why they have disorganized cells. The interesting about the LCIS, the lobular carcinoma in situ, is that usually detected by accident. There are no masses or calcifications. You find it when you're looking for something else. And what we find is discohesive cells because they lack E-cadherin. E-cadherin is responsible for gluing cells together. And if you don't have E-cadherin, there's going to be discohesiveness. And that's what we find in lobular carcinoma in situ. Now, it's very common to find this condition in the other breast as well. And how do we treat it? With tamoxifen, with close follow-up, to prevent the risk of progression to invasive carcinoma. Invasive lobular carcinoma produces a single file row of cells. Yes, because of the disorganization. Is unilateral, it's often bilateral. And over here we see the invasive lobular carcinoma. So of course they lack E-cadherin, and that's why they're so disorganized, as you can see over here, a single file row of cells. Question 71, ER and PR expressing tumor cells would respond to, kind of like a pharmacology and tie in tamoxifen. Obviously, that's what it targets, the estrogen receptors and the progesterone receptors. And over here we see the histology on the left, ER and PR cells. We see the staining over here. ER and PR inside the nucleus, right? They're hormone receptors, so we find them in the nucleus, as opposed to the trastuzumab, which is on the surface of cells. If we were to stain for that, we would see what we see on the right, where we see the cell membrane is stained. Who is at highest risk for triple negative breast cancer? That's going to be Black patients. Male breast cancer occurs only 100 times less than in females and is associated with BRCA2 mutation, something to be aware of. Adnexal torsion is when the ovary and the tube flip around the infundibulopelvic ovarian ligaments. Absolutely is not an emergency. It's absolutely an emergency. It leads to edema, necrosis, and local hemorrhage. Patient presents with a pelvic pain, vomiting, and of course it's an emergency. Now, it used to be that we always just cut off the ovary. Now, actually, in the last about 15 years, they've started to try to untwist them. The most common pelvic organ prolapse is the bladder, and that's in the anterior compartment. This is also known as a cystocele. So that's our scene over here on gynecology. I hope you enjoyed. All right, take care.